cancer, for example, and more aggressive prostate cancer. And overall, that study of 65,000 men and women showed sex difference in height may explain a third to a half of men's excessive cancer compared to women. So men have more cancers compared to women. And it may be more than just genetics. Maybe taller people had different foods when they were growing up, childhood nutrition.
Yeah.
And there's other proteins in the body, an insulin-like growth factor, which may cause height and organs to grow. So this is interesting, and I can't tell anyone what to do about it other than to take note of it. What was the risk factor? For every 4 inches in height, so let's say you're going from 5'4" to 5'8",
Yeah.
there was a 13% increase in developing any type of cancer.
13%.
13.
Wow.
And the most common cancers associated with increasing height were kidney cancers, rectal cancers, thyroid cancers, and blood cancers.
Wow.
And those cancers actually increased by about 25% for every 4 inches in height.
Well, that's pretty crazy. I mean, I had no idea that there was such a relationship, and for it to be so significant, too.
Yeah, well, we're trying to give people information that they may not otherwise hear. I didn't see that in the New York Times or the Post or the Daily News or ABC or NBC. So we're trying to give different information on this show, and hopefully it's beneficial to people who are listening.
Yeah, we're on for another 7 minutes or so, so if you have any last-minute questions, the number to call is 800-321-0710.
And there's a new study about kidney cancer.
Okay.
So kidney cancer is usually detected in people when people have pain in the abdomen or in their flank. They have blood in the urine. Sometimes a doctor will feel a mass. But generally, the kidney is deep inside the body, so it's hard to feel your kidney, and there's no screening done for kidney cancer.
I was just going to say that, yeah.
Sometimes there's blood in the urine.
Mm-hmm.
So sometimes when you go to the doctor, you'll get a dipstick. They'll put a little stick in to find microscopic blood, or sometimes people actually see blood.
But if you don't have any symptoms and you're not going to the doctor, there's no screening.
Right, so it's one of those difficult cancers. Anyway, some people have metastatic kidney cancer, and there's some immunologic drugs now. One is Sutent and one is Afinitor. And the new study tried to evaluate which of those drugs was better.
Okay.
Okay, so there's a new study, and the study tried to evaluate progression-free survival. So it's survival with the cancer being dormant or in remission, and also at survival.
Okay.
And the study looked at these two agents to try to find out which one was better. And Sutent is considered the standard therapy first, and Afinitor is used as second line. So it's a 1-2 kind of treatment.
Yeah, 1-2 punch.
And patients who were randomized in this study to know which, to one of those two agents, Afinitor or Sutent.
Mm-hmm.
And then when the cancer progressed, they switched over to the other one.
Right.
So all the patients had the same two drugs, but
one
in a different
first,
order.
And then the other one, depending on how they started. Yeah.
So would you think it'd make a difference or not? What would you think?
I mean, you know, it's, I guess so. Yeah, probably.
Okay, so you're right. And if you looked at progression-free survival, how long it took for the cancer to progress, if you started with Sutent, the progression-free survival was 10.7 months, and Afinitor, 7.85 months. So Sutent was a better drug to start with.
Okay.
And then they looked at overall responses and median survival. I guess the most important thing for most of us would be how long do you live?
Right.
And the group that had Afinitor first lived 22 months on average, median survival.
More than the other person?
No.
Oof.
They lived 22 months. And if you started with Sutent, 32 months. So it was almost a year difference.
Wow.
So it's one of those studies where it's starting to make some progress, and a year is nothing to sneeze at. Side effects, there was some irritation of the mouth, some fatigue, some diarrhea, nausea, vomiting, low blood counts. So there were some side effects, but you're talking about
10 months difference.
Yeah, 10 months difference. So it's a obviously beneficial to stay in that order. So some people went on a protocol, and that protocol gave the rest of the world information that was pretty useful.
Great. We got a call from Rich from the Bronx.
Okay, so Rich, good morning. I understand that you're talking about pancreas cancer.
Yes, sir.
How are you today?
I'm fine.
Are you the patient?
No, I'm not. It's my buddy's father-in-law.
How old is he?
He's 70 years old.
And when was he diagnosed?
I don't know exactly, but they want to take him to Sloan Kettering. I don't know what the treatment's going to be, but he's in a state of panic.
Well, is it cancer in the pancreas only, or is it spread?
I believe it's only there.
All right. Well, we see a lot of people with pancreas cancers. We see them from all over the world. Sometimes when you go to big hospitals or small hospitals, they recommend surgery. The procedure to remove a pancreas is called a Whipple, which is a big operation. We usually do a staging of the patient. We want to know where the cancer is exactly. We're at the end of the hour almost, so I just want to tell you that I'm happy to speak to you after this hour if you call our number 212-CHOICES. But we do fractionated radiosurgery. Our success rate for pancreas cancer, where we aim the beam, is 90%.
That's what I wanted to know.
So there's non-invasive treatments. You can call us. We'll send you a booklet, and call that number 212-CHOICES. And he may want to see a few doctors to get a few opinions before he makes a decision. That's what I'd recommend to anybody.
Of course. I appreciate you coming on the line, and this is going to be helpful to the man's...
Okay.
It's going to be helpful to his constitution that I spoke to you.
Okay, tell him there's non-invasive treatment that may be beneficial, and we'd be happy to see him and send him information. Thank you very much.
All right, we got another call, John from Manhattan.
John, I hear you're calling about microscopic blood in the urine.
Yeah, but I've had it for at least 30 years now.
All right, well, we're just at the end of the hour, so I'd urge you to call me at the 212-CHOICES number, either later today or during the week. We'll send you information.
Okay,
212-CHOICES?
212-CHOICES, 212-246-4237. We have a booklet and a DVD. We send it free to people who call, and I'm happy to speak to you privately. But unfortunately, we're at the end of the hour, and we have to close up the show until tonight. If you want to call back tonight, we're on WOR tonight at 9 to 10 p.m. So thank you for calling, and thank you for the listeners for listening to us, and we hope you find this information useful. Dayush, Eddie, Reggie, thank you.
My pleasure.
Again, we're on ABC Radio Saturday morning from 6:30 to 7, and WOR at this hour every week and at 9 to 10. So thank you. Have a great week, and God bless you.
Thanks for tuning in to the Radiosurgery Hour with Dr. Gil Lederman and myself. If you have questions before next week's show or want a free informative booklet and DVD, just contact Dr. Lederman at 212-CHOICES. That's 212-246-4237. That's 212-246-4237. Till next week.
The proceeding was a paid program. WOR's airing of this program constitutes neither an endorsement of the products offered or the ideas expressed.